welcome Professor Khosrow to host the IFCC and the Mindray LabTalk Webinar. Hello, Professor Khosrow.
Hello, everyone. I'm pleased to be here to open this very interesting symposium on quality assurance, quality management, both in hematology, in chemistry, and in general in lab practices. Quality is everything when it comes to laboratory testing. As you know, without high quality operations, lab results cannot be relied upon, and physicians, the public, the patients all depend on labs to ensure high quality results. So today's discussion on quality management and quality standards is very important, and we have four excellent speakers with us. I'm going to share my screen. We have four presentations, first by Professor Egon Amann from Germany on total quality management, then followed by Professor Tony Patrick, who will talk about ISO 15189 and how it is critical when it's implemented to improve patient outcomes. Then a presentation by Professor Esin Avci from Turkey, who will talk about quality management, specifically in hematology and the use of the lab expert. And then followed by Professor Castillo, who will present on optimization and development of blood cell analysis. After the four presentations, we will have about a 20 to 30 minute discussion or Q&A session. So please keep your questions at the end. You can submit your questions through the Q&A or the chat, and we will answer them when we get to our roundtable discussion. So I want to start by introducing Professor Egon Amann. Professor Egon Amann is the co-chair of the IFCC Task Force on Global Lab Quality. This is an important initiative of the IFCC to enhance quality management across the world, both external quality and internal quality assurance. And Professor Amann is from Germany. He's an independent consultant in life sciences, quality systems, and clinical chemistry, and Professor Emeritus of the Philipps University of Marburg and University of Applied Sciences in Hamm-Lippstadt, Germany. Then we will have Professor Tony Patrick, who will be, as I mentioned, presenting on ISO 15189. Professor Patrick is very well known in the area of quality management. He's the CEO of the Royal College of Pathologists of Australia in the area of quality assurance programs based in Sydney, and chair of the Education and Management Committee and the Scientific Committee of the Asia Pacific Federation of Clinical Biochemistry, and the chief examiner of the Faculty of Science and the Royal College of Pathologists of Australia. This will be followed by Professor Avci, as I mentioned, from Turkey. She's assistant professor of medical biochemistry department in Pamukkale University in Turkey, lab quality management director, and the lab head at the University Hospital Central Laboratory. Our final presentation will be by Professor Carolina Prieto Castillo, who is from Latin America, from Brazil, currently based in Chile, Formato Clinical Chile Director, as a medical pathologist. She's also the Vice President of the Latin American Clinical Pathology and Lab Medicine in the area of international relationships. So that will be followed by our Q&A session that I will be happy to coordinate. So we will have a roundtable discussion at the end. So I'm going to stop here, and then we have a presentation by our Mindray colleague. Please go ahead.
So we will welcome Mr. Ke Wen give us the opening speech.
Okay, thank you very much. I hope I can be heard. I'd like to thank.
I'm sorry, Professor Yigang. Just wait for 3 minutes. Our general manager, Mr. Ke Wen, also want to give an opening speech to everyone. Thank you, Professor.
Okay.
Thank you.
Thank you.
Yeah, sorry, sorry, Professor Yigang. I think the internet for the Ms. Ke Wen have some problem now. So I think you can start now. I'm so sorry. Yeah.
I think it is better if you start with Professor Aman's presentation, and then Mr. Zhu can present when he's available.
Yeah. That's right. Thank you.
Okay, thank you. Professor Aman, please go ahead.
So sorry for this problem. Thank you.
That's okay, please.
Yeah, thank you, Professor Adeli, for the kind introduction of the speakers. I just want to make sure that I can be heard properly and that you will see my presentation, which I'm now going to start. So
Yes,
just a
thank you.
question, can the first page be seen?
Yes.
Okay, then I'd like to thank Mindray and IFCC to have a chance today to give this talk about total quality management in hematology and clinical chemistry. And I will give sort of an overview, if you wish, and I will just continue. What can you expect from today's talk? This is my outline for today. So basically, I'd like to talk what is quality in laboratory medicine. Then I will talk about the quality ladder and how can I reach quality in my laboratory setting. I would like then to shift briefly to a case study implementing quality in Africa. And that goes back to my experience, and I served as a IFCC officer for a project developing quality and in Africa, and that relies a little bit, and I think we can learn also from this experience. And then I would like to have a few information about current challenges and the future of clinical diagnostics, which we are all facing. So I'd like to start then and with the quality in laboratory medicine, what this is all about. So if you actually look for definitions of quality, you see in the dictionary, it's a degree or grade of excellence. And the International Standards Organization talks about a degree to which a set of inherent characteristics fulfills requirement. So that's rather abstract. And what does it actually mean? And I want to show you different viewpoints from perceptions of a quality test. So the manufacturer may say it should be CE marked. The lab director may say allows us to maintain accreditation. The lab manager is asking for maybe an inexpensive, requires unskilled staff. Technologists will say it never fails IQC. The lab consultant may say high clinical sensitivity and specificity. The physician may say available at the bedside, whole blood, maybe point of care. A pediatrician requires very small sample volume. And the patient, last but not least, would like to have a quick answer and a clear result. So we can see that this is quite a different perception on quality. And this is just giving one example, a blood glucose measurement in the same patient. The technologist in the lab thinks I'm following ISO 15189. The nurse in a diabetic clinic has a different ISO regulation. And of course, the diabetic patient in own home has no standard at all. So you see, quality can be viewed at very different angles. And then the question is always, what is my goal? Do I aspire for perfection? And maybe we can structure this and say we have a sort of a substandard, which is not sufficient to run the operation. Minimum definitions may be required. Then I go into an adequate situation, median practice. Maybe it's then over time becoming much better. And it's a really good quality I can guarantee. And of course, I'm asking and for an aspiration for a perfect target. And this is even considered in the standards continuous improvement, apparently. And so that is an interesting graph, I think, because it actually is applied to many things, also to quality. So let's say a big rise in quality standards you have quite easily with a minimum resources. But then it becomes much better. You have additional quality possible, but greater resources is required. And then you may be already at a 90% level, and then it will be very difficult and only little gain in quality despite considerable extra resources will be possible. And so assuring quality in every laboratory, of course, very key to this quality is not something from the quality department. It's a responsibility of everyone. That's very important to consider when we talk about implementation of ISO standards. And I don't need to write now all these terms. You can do this for yourself. But of course, all these terms tie into a quality process, into quality procedures. And of course, last not but least, it must be cost effective. And then, of course, we have all these at the right-hand panel, the records, equipment, audits, etc., which is needed for quality. So if you just take a simplified look at things, what is laboratory medicine all about? And we could say here the total testing process, in short, TTP. So basically, the patient goes to the doctor, and the doctor does some interpretation, and he may ask now for a laboratory medicine test. Yeah. Of course, at this stage, step number 3 would tie into laboratory medicine phases. And we know these phases very well. We have the pre-analytical phases, the analytical phases, and the post-analytical phases. And once this is done, the report will then be given, step number 5, back to the doctor, and the doctor will talk to his patient and will provide the result to the patient. So we are talking about, of course, the laboratory medicine phases in this webinar session. And a well-known fact is, if we look at errors in those different phases, pre-analytical, analytical, and post-analytical, it's now well established that, in fact, the most errors occur in the pre-analytical phase. There are, I just cited one literature right here, there are many more these days. The second error-prone step is the post-analytical, and it's already remarkably well established. So the lab errors in the analytical phase is below 10%. So we must consider always the pre-analytical and the post-analytical phases when we think about quality improvement. I'd like to shift now to my second part, which is the simple quality ladder. And if we go through these phases, of course, core to every laboratory medicine is the analytical phase. And that is basically the first step on our ladder. And we have, of course, these stages. We have the internal quality control, we have EQA, we have the analytical goals, we have action limits. So that is our analytical and everyday issues. And we can, of course, discuss what are the laboratory support to fulfill those requests. And in the EQA, even the assay may not fit for the purpose. And would be then the pre-analytical, where we already know, have seen there will be many errors possible. And what this is all about, it's about the test selection, right test, right patient. We have the sample collection, and this must be all done as laid out here. We have the sample transport, we have the sample receipt. And again, here we can expect laboratory support, and this can be fulfilled, for example, by instructions and guidance or educational support, feedback and audits, and of course, the discussion with the users. And then what can go wrong? Again, we may have inappropriate investigation. Maybe we use an incorrect specimen. The specimen may be compromised. And of course, again, it's a wrong outcome and patient safety issue may occur. So that's also a 3-step approach how we can improve our pre-analytical phase. The next step up the ladder would be the post-analytical phase then. And again, here we have questions like test validation, the reporting, critical values, if we have values outside the agreed limits, how is interpretation, how is the report receipt and the follow-up. And again, laboratory support is manifold. We can have discussion with the user, we have guidance and advices, we have educational support, and of course, maybe we have clinical audits. And also here, things can go wrong, starting from an invalid result, maybe a vital result may be overlooked. And then we have, of course, incorrect interpretation and wrong action. And again, we have a patient safety issue at this level. And with these rather simple steps, not simple steps, let's say time managed steps forward, we can reach a step 4, which then is a quality management in the laboratory, and we can go for lab accreditation. And with this simple, and go back to my previous slide from before, of course, it's then very important that we have a laboratory accreditation. We have analyzed at a very detailed level our 3 phases: pre-analytical, analytical, and post-analytical. And in the end, we will fix this and have a tying our TTP together in this process. And of course, now you can ask yourself these big question marks. Where do I stand with my laboratory on the quality ladder? And we have listeners around the globe, and you can ask yourself now, where do we stand if we take this simplified approach with my ladder? And of course, I want to mention patient safety is always at the core of this business. And the first rule of medicine, of course, is do no harm. And poor quality laboratory medicine can harm patients by missed or delayed diagnosis, incorrect diagnosis, and this leads to incorrect treatment, unforeseen clinical events. And I make reference to this paper, when diagnostic testing leads to harm, a new outcomes-based approach for laboratory medicine. So I like to shift to the topic number 3. How can I reach such a quality more on a practical implication? And this is a slide where we can, where we look now at a different order. We went a bottom-up approach so far with the ladder. Now we take a top-down approach here. If you are registered and accredited to, let's say, ISO 15189, we have a quality policy, we have the quality assurance, all actions designed to ensure the quality of diagnostic results. And then we have, of course, this block down here, the quality control, and that's, of course, always internal quality control and the external quality control. There are, of course, other aspects of good laboratory practice which is not depicted here, but which is equally important to this. And one way to actually approach this is also again in a stepwise approach. And we see this LQSI tool, and we have listed now here the different quality systems essentials, starting with facilities and safety, over organization and down to continuous improvement, as mentioned earlier. And then we can say, let's ensure a primary process of the laboratory operates correctly at safety. And then we have to fulfill these phases, these points concerning the quality system essential. And if that's reached, actually, we go to controlling and assuring quality and creating traceability. And that's already a phase 2. And we see here new terms which we can add to this quality systems essential. In a phase 3, we ensure proper management, leadership, and organization, and add more things like here. And then at a phase 4, we are able to create continuous improvement and prepare for accreditation. And this can be, again, depicted in a different way. We have resources, we have processes, and we have this continuous improvement. And you see this has an old column, so that's important. And again, all these aspects are aimed in getting pre-analytical, analytical, and post-analytical improvements. And a very practical way to actually go around with these rules is this 9 points which are listing here. So of course we have to familiarize ourselves with the ISO standard or any standard, depending on what we would like to achieve here. Then you go and say, does it meet your needs in time and effort, energy and money? You should have a gap analysis performed here. Then you prepare the lab information and education guides and culture. Number 5, develop an implementation plan. Do a Gantt chart, for example. Then you repeat the gap analysis and determine your state of readiness. And you make a decision under point 8, do we want quality or accreditation or both? And then you commit to the standards. And this is just an overview. This just should tell you we are a highly regulated industry, and there is a multitude of regulations. And I've just listed here the medical laboratory, starting with 15189, but also the notified body in Europe is regulated. Accreditation body in any part of the world is regulated. Calibration labs are regulated, proficiency test providers, manufacturers. And of course, this is just an example. There are many, many more. And this is a lot of a burden. We have to study those. We have to keep updated on these different standards. And this is just going quickly over this. Of course, these ISO standards, and here is an example, 9001, goes through over the year, over constant revision. And the revisions will be published, and it always is a lot of burden to now go from the 4th revision to the 5th revision. We have to do many things in the laboratory. This need to be changed. So I like to switch to implementing quality in Africa. And I mentioned already, this is going a little bit back in my experience. We had visited and made workshops in some African countries. And it's very clear that many of the African countries are still belonging to the developing world. And the question is simply, how can quality be implemented here? And there is a WHO guide for the so-called stepwise laboratory improvement process toward accreditation in the African region. And there are 2 terms I'd like to tell you. One is a SLIPTA, it's a stepwise laboratory improvement process towards accreditation in the African region. And the other is SLIMTA, SLMTA, the strengthening laboratory management towards accreditation. And the overall idea here is really, goes back, I don't want to read this to you, to a WH guideline. It was in Kigali, Rwanda in 2009, where this actually saw the light and was implemented. And the basic idea is for many, many labs, it's just not possible to get a quick accreditation 15189. So let's just do a stepwise approach. We are defining so-called stars going from 0 star to 5 stars, and we are scoring points in the stepwise approach, how we can reach those points. And this is just giving examples. I show you in the next slide these points. So you can earn yourself points in different categories, and you see the sum of the points goes up. And in the end, you may end up with a lot of 5 stars and are ready for accreditation. And this is how these points are actually distributed over these different sections in the SLIPTA checklist. And you have these different sections. And as you see, there are different points now given. Let's say, just an example, internal audit is just given 10 points, but equipment is given 30 points. So there is a weight with this. But in the end, you can reach 258 points, and then you would be 5 star and would be absolutely ready for accreditation. And this leads again to my quality ladder. So now from a bottom-up approach, you have to have internal quality, you have to have the external quality. You may have a local liaison, internal liaison accreditation scheme, and in the end, you may reach, in fact, accreditation to 15189. And yeah, it's a daunting task, and the African labs should not be frustrated and really take a stepwise approach. And this is just explained in these words. So basically, you do a stepwise approach here. You could start by reducing method imprecision. You improve accuracy of your results. You establish maybe a peer group with a local liaison. Inform on the international context. Maybe you are already now at the route to accreditation and ties together, and then you are basically done. Of course, this is done with independent assessment by an accreditation body. And again, the same ladder, just assuring analytical quality at the very bottom, implement a national EQA scheme, and then establish a quality system in line with ISO 15189. So I'd like to come to the end with a few challenges and the future. And I would like to pick one important point, which I personally find very important, and this will be a challenge for many years to come, and that's interoperability. And interoperability is now talked a lot, let's say in MedTech Europe or co-chair. It's also talked a lot in many countries. And what does it actually mean? What is the vision? What is interoperability really mean? So in the European Medical Device Regulation 2017/745 and the In Vitro Diagnostic Regulation 2017/446, it's defined as the ability of two or more devices, including software, from the same manufacturer or from different manufacturers to exchange information between these systems, communicate with each other, and work together as intended. And that's even now a little bit expanded definition by the Health Information and Management System Society, which is a global health IT membership. And they are saying interoperability is the ability of different information systems, devices, and applications to access, exchange, integrate, and to cooperatively use data in a coordinated manner within and across organizational, regional, and national boundaries to provide timely and seamlessly portable of information and optimize the health of individuals and population globally. And this depicts maybe more visually what this is all about. The patient monitoring continuum, it starts these days with a healthy lifestyle and fitness applications. It starts with managed chronic conditions, post-discharge monitoring, general ward and ambulant. So how can this be all connected, and how can this be safely done and under not disturbing data protection laws? And this is a big challenge, and many companies and institutions work on this to get this actually done. This is just food for thought at this stage. I can't talk much more about this. And of course, things go on in a regular way. We have new symbols for compliance with the IVDR. We have these signs, they were new to me, for self-testing, not for self-testing. So this is constantly changing and going forward. And with this, I come really to an end and just have a few points here listed, which I think will define the future of clinical chemistry and lab medicine. As I mentioned, systems interoperability, not just device connectivity, there'll be much more. There will be big databases behind this, clouds will be behind this, and this means we have artificial intelligence, data science, and laboratory medicine across destinies. We have to focus on more outcome-based models. We have to continuously work on reducing measurement and uncertainty. Of course, it's a constant advances of IQC tools and techniques. The commutability is a big topic of reference materials within IFC, the internal quality control. EQA will be more important. And then, of course, patient-based real-time QC, standardization will continue. We have a variety of novel biomarkers. Think about molecular biomarkers, RNAs, for example. And of course, we have an ongoing miniaturization. And last but not least, it's motivation and of the human beings working in clinical chemistry is the most important thing. So this would give probably topics for many, many more talks. I just want to end by pointing your interest to a few publications and resources which was developed by the recent Committee of Analytical Quality of the IFCC. And just giving for you the references, we have a patient-based real-time quality. Tony Battrick will the next speaker. The quality management, some fundamentals of external quality assessment. And one further, there is a resource table in there where you can find a lot of interesting things, let's say for quality-related document, or how do I set an EQA up. There's a checklist. You can work along the checklist here. You can work on planning EQA schemes. So it's a lot of interesting side, and I would like to draw your attention, and please check it out. It's on the IFCC resources and publications server. And this is my last slide. So basically, it's for me very important. Quality is not a self-fulfilling prophecy. It adds simply also for many things. The user satisfaction. You may have new customers. You may have better research collaboration. You may participate in clinical trials, and this will be ending all in the basket. So quality will help you in all aspects. And with this, I would like to thank you for your attention, and we will go into a discussion a little later. Thank you very much.
Thank you, Professor Aman, for that excellent presentation. We're going to now move to our second presentation. As I mentioned, the questions will be addressed at the end of the QA session. So I'm pleased now to introduce our Professor Tony Battrick, who will be giving our next presentation on ISO 18109 and the importance in basically ensuring highest quality management in the lab and improve patient safety and patient care. Tony, please go ahead.
Thank you very much, and thank you to the IFCC and for inviting me to give this presentation, and thank you for the support of Mindray as well. I'll just find my solution. Can everybody see my presentation?
Yes, you can.
Okay, so I'm going to talk about ISO 15189 and how it can be used as the basis for a process or a system to improve patient outcomes. But I want to speak about some other things as well that are related to trying to improve patient outcomes. You need something like 15189, but you need other things as well. And I'll talk about the concept of traceability and the concept of risk as well. So quality, and we heard from Professor Aman about one definition of quality, and there are many definitions of quality depending on the application. I'm going to use the WHO classification or definition, which is that it's related to, I say, accuracy, reliability, and timeliness of reported test results. So the laboratory results must be as accurate as possible. And some of these terms we really need to think about, but they need to be accurate. All aspects of laboratory operations must be reliable, and the results must be produced in a timely manner that's useful in terms of being able to intervene in the patient diagnosis or treatment. So there's a lot of things there. It's not just about doing the assay appropriately. There's a lot there about the efficiency of the laboratory, but also the processes around the communication between the laboratory and the clinician. What does accurate mean? And there are many definitions, but I think what we've learned over the last couple of years because of the COVID pandemic is just how important pathology testing is. I think we all knew how important pathology testing was. But now I think the whole public, the whole world is aware of how important pathology testing is. And we also know, because of the COVID pandemic, particularly in terms of population health, we can understand what inaccurate means. So this is just an article from an English newspaper where it was reported that there was a laboratory in England that produced a whole series, about 43,000 false COVID negative results. So there were 43,000 patients out there with a positive COVID who the laboratory said were negative. So that shows you the sort of damage that can happen when laboratories make mistakes. If we think about how can we reduce error, how can we reduce patient mortality and morbidity, how can we improve patient outcomes? This is a very neat little diagram that was produced in the Harvard Business Review a few years ago in an article written by a surgeon. But in fact, the same principles in terms of reducing bad patient outcomes can be applied to laboratory medicine. So that's what I'm going to talk about, how this can be applied to laboratory medicine. There's three waves of innovation whereby you improve patient outcomes. The first wave is related to technical advancements, and in our case, better equipment, analyzers that can be more accurate, smaller sample, faster, more precise. That's the first wave. The second wave is about the standardization of procedures. So this is about checklists, process compliance, quality measurement and feedback. So this step is actually about quality systems. So the second step, after you've got reliable equipment, the second step in laboratory medicine, where you can improve patient outcomes, reduce patient errors, and improve morbidity, is in fact to introduce a quality system, such as ISO 15189. There is another phase, and it's termed high reliability organizing, but it's really about the people. So if you look at these three phases, the first phase is about the equipment. The second phase is about your systems, your quality systems. The third phase is about your people. And really, if you're going to improve and get the best outcomes for patients, you need to look at those three areas: equipment, systems, people. This is just a slide about those high reliability organizations, but it's all about focusing on people. A bit about culture, something about leadership, something about learning, something about problem anticipation, but it's all about people, it's all about training, it's all about, as Professor Aman said, about motivation, it's all about competence. And the organisations that are seen to be the best in terms of reduced error, lowest error, are organisations such as air traffic control, aircraft carriers, nuclear power plants, and organisations such as NASA. But I also would like to put laboratories in this group as well, particularly when you see or consider how laboratories have coped with the pandemic. And there are papers out there that can that I'll leave here that you can read, so you can see what's the next step. How do you involve people in these processes to reduce poor patient outcomes? But going back to the second step, and that's about quality systems. So the quality systems approach, Professor Aman spoke about total quality management. These things are really focused on those principles of total quality management, or the quality management principles. They involve looking at your customers, knowing what they want, having an appropriate leadership that can react to all these factors, engaging your staff, having a process approach, looking at continuous improvement, making your decisions based on evidence, and relationship management with your suppliers, as well as your referring doctors, as well as all the staff if you're in a hospital who are associated with your lab. the common elements in quality systems, and these are the common elements in the ISO quality systems. They're the common elements in 15189, 9000, 14000, and 17025. They've all got the common structure, which are those things we just talked about then, the TQM structure of customer focus, leadership, engagement of people, process improvement, evidence base, etc. So when you look at the clauses in 15189, you will see these underlying principles, but you'll also see the same underlying principles in those other standards, because they're core to total quality management. So what does ISO 15189 accreditation give you? It gives you competence to perform specific testing procedures. That is, it's a quality management system that's documented, fully operational, and conforms with all those elements of 15189. Though again, as the previous speaker said, if you're in a developing country, you may not be able to meet all of those, but you can work towards meeting all of those over time. It's an adherence to any additional requirements that might be established, including traceability, and I'll talk about traceability soon, and proficiency testing or EQA. They're also requirements of 15189, because they're key, as we've heard before, to ensuring that your laboratory actually produces the same results as other laboratories doing the same test. But it is a minimal standard. So even when you achieve 15189, there's more to go. And that's where the next phase, which is these high reliability organizations involving people, that's the next stage to continuous improvement. The advantages of adopting a management system such as ISO 15189 is that there's proactive quality improvement. And the proactive quality improvement is driven by the use of non-conformances and audits. And management review. Management review ensures that there's oversight by the senior leadership and that there's accountability for the operations of the laboratory, and any errors that are identified either by the non-conformance system or by audits, and to ensure that in fact there's quality improvement. And that documents become the basis for practice. That leads to standardization of procedures and approaches. External audit by an external agency also is very important, in that it ensures that the laboratory really is improving and meeting those standards. The problems with some of the systems that are inherent in ISO 15189, these are the systems related to the non-conformances, is that often when we look at our non-conformances, that there's a lack of cross-functionality when we do when we try to find the reason why there was a problem. We don't always bring enough people in, and we move very quickly through the non-conformances. We don't go for the sort of the proper root cause analysis. We often look at them reactively in terms of errors rather than proactively. Often the CAPA system is overused rather than underused. So the non-conformances are overused. We find too many non-conformances, but not the right ones. As I said earlier, there's a poor root cause determination, and often there's a poor definition of the whole process. So ISO 15189 relies upon the non-conformance system and the audit system, but they have to be done properly. People say the problem with going down the pathway of quality management is that it's costly. It'll cost me money. I have to spend money with putting these systems in, with training people. It's expensive. But in fact, that's the wrong way of looking at it. It's an investment. Improved quality and implementing a quality management system does improve your quality almost by its very definition. It actually reduces costs. It reduces costs because it produces more focused or motivated staff. That they know what they have to do. They've got a process to improve what they do, and good staff will in fact act on that and reduce errors, reduce waste, and reduce your costs. And the processes that you implement will reduce error in other ways. They'll reduce the number of recollections. They're highly costly. Reduce the number of failed runs, lost specimens, improve your training, reduce waste. So all those things will in fact reduce your costs. This is just some work that I was involved with recently, where we did a large-scale survey in Southeast Asia and China, and we looked at the association between a whole series of factors by survey and productivity, laboratory productivity. And what we found, surprisingly, very surprisingly to me, was that those labs that had international accreditation, such as 15189, actually had higher productivity. It's an association. It's not a direct correlation, but there was an association. And we saw that both in Southeast Asian labs and in Chinese labs. The impact varied depending on the size of the lab, but there's a relationship between accreditation and productivity. So again, here's evidence that in fact your costs don't go down. But certainly looking at the literature, there's a lot of support out there in the literature to show that introducing ISO 15189 leads to better patient outcomes. It was really summed up very nicely by Michael Noble from Canada in a paper where he said that there's strong argument that improved quality in medical laboratories improves patient care and patient safety. And he concluded with, despite the absence of clear evidence that external evaluation of laboratories leads to improved patient safety, indirect evidence does in fact lead to that conclusion. So there's indirect evidence that in fact there's an improvement in patient outcomes, and now there's starting to become evidence that in fact there's improvement in laboratory efficiency. What are the greatest sources of error in laboratories? High-risk tests, where there's a large impact for the wrong result, such as we saw with COVID. Tests that are used to support the clinician's decision in isolation. So if a clinician will rely totally on a result and then treat, so that can often be something like troponin, or tests that are acted upon immediately, such as in the point of care situation. Or tests performed on specimens that are difficult to collect. So it's unlikely in that situation the specimen will be recollected. So these are high-risk situations. So not all testing has the same risk associated with it. Not all testing has the same risk associated with a poor outcome for a patient. These are situations where the risk is higher for particular testing. So we need to be aware of that. So this is a large laboratory, and as I've said, there's a lot of equipment there. So they've got phase one there. There are systems going on in this laboratory, but often what we forget about in our quality systems approach is the people. The people are core. And this is some results from a series of American accrediting agencies, where they ranked, there were 5 agencies in the US that accredit laboratories, and they ranked in order what were the highest error rates in laboratories when they did their accreditations. And you can see here that testing personnel competency is one of the highest error rates found by these agencies. And this is common across the country, all countries. Also errors in procedure manuals, how well external EQA was evaluated, and the lab director not fulfilling their tasks. A method evaluation and standard operation procedures also were poorly done. But competency of staff is core. We did some work a little while ago in Australia, where we looked at the laboratories that performed at the highest in our EQA scheme. So we provide EQA to a whole lot of laboratories. We looked at those laboratories that consistently did very well in their EQA, and we asked them, why do you do so well? Is it your IQC? Is it your training? What is new equipment? What is it? And in fact, the answer that came back was that it was that all these laboratories had got new equipment recently. And that was a little bit disappointing. But when you actually think about what that means, when a laboratory gets new equipment, immediately there are no experts in that analyzer. The people who used to be able to be the experts in the old analyzer now, they're no longer the experts. New piece of equipment comes in. The people who are going to be the experts in using that piece of equipment are trained by the experts from the manufacturer. So they become the experts. They're the most competent people trained by the experts in training to use that analyzer. And then that's when we believe the laboratory performs best. When the people who are using the equipment are the most competent that they can be. Over time, what happens is that those people leave or they train somebody else, and often the training systems aren't that good. So bad habits are passed on from one person to another. And that's why the quality in the laboratory goes down. So training and competence is critical, as well as having equipment, as well as having quality management systems. I'll just stop for a minute and I'll let you look at that. And I'll let you think about what that's a picture of. Okay, what that's a picture of is a cow. So it's a black and white picture. If you look over to the left, you can see there's an ear. I don't know whether my pointer works. There's an eye, there's another eye, there's an ear. So I only put that in there after I've given that example of the best laboratories get new equipment. Sometimes what's staring you in the face is not obvious. It wasn't the new equipment, it was the fact that the operators were highly trained. They were trained by the best trainers that there were. That's the important lesson to take away from that. Competence of staff, well-trained staff make all the difference. I just mentioned, and again, Professor Aman mentioned about pre and post analytical errors. There are EQA schemes that look at those errors. And what's important when you look at pre and post analytical error isn't that you count how often a particular error occurs. You have to look at how risky is that error. So there are some errors where, for instance, with pre-analytical error, sometimes a specimen isn't taken. That's one type of error. But there are other errors, such as wrong blood in tube, where the specimen has been collected or labelled from the wrong patient. Those two errors occur at different frequencies, but wrong blood in tube is the most important, the highest risk error that you can have in a pre-analytical situation. So the frequency of an error, it doesn't equate to how important that error is. So you need to modify by adding a risk factor to, particularly when you deal with pre and post analytical factors, you need to not just count, but you need to add a risk to the type of error that you're measuring. And this is just some data from that survey where we look at a whole series of different types of error, hemolyzed specimens, sample clotted, incorrect fill, etc. So these are some of the pre-analytical errors that we measure. But what's important here is not just the frequency, not just how often these errors occur, but what's more important is what's the risk associated with those errors. So you will see they're the same errors in both the left and right histogram, but in the right-hand side, there's a risk factor added. So the highest risk are the errors, the pre-analytical errors that we need to work on. So that we just don't need to count in terms of pre and post analytical error. We need to count what's important, what's the highest risk. So again, just reinforcing that, this is from another paper by Parvin, and this is from CLSI EP23. In terms of what's important, you need to take into account error and risk, sorry, not just error, but risk. So this relates to the reliability of the measurement procedure, the effectiveness of quality control, the likelihood that the erroneous patient error has been reported, and the likelihood of harm that could be caused by that error on a patient. And in fact, we measure risk over time, and we've in fact been shown that over time, in our situation, in Australian labs, the risk is increasing. So that's very interesting, I think. So risk comes from really not knowing what you're doing, but risk is important. We don't need to just measure how often something occurs. We need to measure what's the risk to the patient. They're two different things. So now the last thing I'd like to talk about is, we talked about accuracy, and there are a lot of different factors associated with accuracy, but we need to ensure that we're measuring the same thing. We need to ensure that when a patient gets a sample for something to be measured, that different laboratories that were given that same sample get the same result. That's what EQA is all about. But if the same patient gives the same sample in two different laboratories, and those two laboratories give two different answers, there's going to be a bad outcome. So even with the best laboratory management system, the best equipment, the most trained staff, if those two laboratories produce different results on the same sample, there's going to be a bad outcome for the patient. So that's all about trying to harmonise results. So there's a lot of work going on now, trying to ensure that that situation doesn't occur, that in fact that laboratories are harmonised in terms of the same sample requesting the same assay in two different laboratories will get the same answer. So that's exactly what I've got there. So you want to make sure that there's one result comes out from 3 laboratories measuring the same thing, not 3. So that's about traceability, meteorological traceability, and it's the property of a measurement result whereby the result can be related to a standard. So you want for a particular assay, if you're measuring creatinine, for instance, you would like that all laboratories have their method that they use to measure creatinine standardized against some universal standard, so that all methods really at their core are measuring creatinine in the same way. So to harmonize means to make consistent. That's what we would like to do. We would like to make all our assays consistent. That's not always possible because sometimes we don't have those reference methods and we don't have those reference materials that would allow us to, at some stage, have a material that we can define to have an exact value of creatinine, for example. So there's 2 ways of doing it. The first method really covers the traditional meteorological scheme, that hierarchy, which I'll show you in a minute, where you do in fact have very high level reference measurement systems and very high level reference materials. The second method uses inter-method comparison schemes, where we couple different methods to ensure, and we factor them so that we ensure that different laboratories using these different methods will end up getting the patient with the same result. This is a typical scheme. You've seen this sort of traceability chain before, where for our best methods, if we do have a reference method and we do have reference material available, we can have an unbroken chain between a reference laboratory somewhere using a reference method and a reference material back down to the method that we use in our laboratory. And by doing this, we ensure that for those methods, they will all, at the laboratory end, at our user end, patients will get the same result. This is very important. And traceability requires a lot of work. It requires, as I've said, the presence of certified reference materials, reference methods, reference laboratories. Really, if we could do this, we would have universal reference method limits, reference intervals, sorry, and decision limits across the world. We need EQA schemes, and we need accreditation of laboratories, and we need manufacturers obviously on board. So this is a very complex process, but this is where laboratories will go in the future. So in summary, really, I've talked about lots of things, but we need the adoption of common laboratory standards for practice to reduce variation in patient results. And that's all about standards such as 15189. We need to reduce variation in operations and process by implementing, say, quality improvement processes in laboratories and training and competence assessment of staff. And we need standardization and harmonization of methods to reduce variation in methods from all laboratories. So it needs to be a global effort from all those people that you saw in that last slide to in fact ensure that a patient will get the same result from any method in any laboratory. Thank you.
Thank you very much, Tony, for that excellent presentation. Just 1 second, please. We're going to move on to our third presentation by Dr. Afshi. Please go ahead.
I cannot share my presentation now.
Please.
Can you see, Professor Adali?
Yes. Just full screen, please.
Yeah.
Thank
First,
you.
I would like to thank Mindray Corporation to invite me as a speaker in such a valuable meeting. I will try to explain our complete blood count quality management adventure in our hematology laboratory. My title is Quality Management in Hematology Laboratory and State-of-the-Art Lab Expert. My presentation plan is above, as you can see, what's the quality management, assurance, and control. What's the total quality processes and their steps, pre-analytical, analytical, and post-analytical phases. I mean about the state-of-the-art and state-of-the-art lab expert, and then quality control management in analytical phase in complete blood count, and how could we benefit lab expert. Mainly, I would like to explain what are the quality requirements in complete blood count and main implementations in practice. Quality assurance and quality control are two aspects of quality management system. Quality system, the first quality management ISO 15189 document is the first document for the medical laboratories. Quality assurance is the sum of all activities and procedures undertaken by medical laboratories to improve the quality and clinical usefulness of laboratory test results. And the quality control is one of the most important impacts on laboratory testing, and it ensures both precision and accuracy of patient sample results. Professor Egun and Professor Tony explained the quality and how can we define it. Quality is important. We should do that by using the best cost, understand the quality requirements in process. Transmission of the test result to the ordering physician. Then pre-analytical phase starts. Pre-analytical phase pointers, tube selection, phlebotomy, appropriate blood levels, turn upside down procedures, transfer conditions, and specimen reception unit. There are some CLSI guidelines optimizing this phase, such as CLSI H3A6, H18A4, H21A5. After this period, analysis going on. Laboratory professionals are expert in this area for creating the great result. Or laboratory professionals in the laboratory. Post-analytical phase is the final phase of the total testing process and involves evaluation of laboratory test results, release of tests in a timely manner to appropriate individuals, particularly critical results and modification, annotation of results, because controlling these steps is very difficult. Every steps are conducted by another health staff. Approximately 60 or 65% errors occur in this stage. On analytical phase, wrong region storage temperature, electrical interruption, expired regions, and non-conformity with QC are the frequent errors that due to 15–20% errors. On the post-analytical phase, communication errors, delayed results, transcription, and the data entry errors, misreporting reference results are the common problems. These phase errors constitute 15 or 25% of the total errors. And then analytical phase starts. We are using called 8000 systems cell auto-analyzer in our hematology laboratory, and we analyze complete blood count parameters by using photometer, electrical impedance, and light scattering methods. Our workload is approximately 800–1000 hemogram samples every day. And state-of-the-art lab expert. The term has been used since 1910 and has become both a common term in advertising and marketing. It's meaning the best available. It has been using the best modern techniques and development. New, futuristic, ultra-modern laboratory techniques have been developed in recent years. So it is more common in laboratory now. Many automation systems are using the development technology and the information system. Lab expert meaning supports this term, state of art, gives us so many useful information about patient sample and sample processing. Sample list, patient information, sample results, sample historical results, and rules are triggering on this menu: critical value, auto-validation, manual validation, and validation rules on this menu we can see. Also patient graphics. Patient graphics and flags can be seen on this menu. But first of all, before using the state of the art, we fulfill the requirements to work well now. To ensure a perfect analytical phase, some requirements should be done before setting the auto-analyzer in clinical laboratories. First of all, manufacturers must conduct validation of their instruments in accordance with some requirements. ICSH and CLSI document H26A2. During the implementing process of a new hematology analyzer in a clinical laboratory, it's mandatory data verification process is performed to ensure that the analytical performance is up to standard. In general, end-user laboratory should follow the principles and procedures of the manufacturer's validation, although those may be abbreviated as determined by each laboratory director. The examinations are carried over precision, analytical measuring interval, comparability, interference, clinical reportable intervals, accuracy, reference intervals. And they have to do this according to some guidelines. For example, CLSI document H26A2, ICSH documents. To ensure the safe and valid clinical interpretation of test results, objective analytical performance specifications are needed in clinical laboratories. Quality assurance in analytical phase requires well-designed quality control planning. Laboratory physicians should define their own quality goals. For acting the quality goals, the current performance should be monitored. Analytical quality goals indicate how laboratory tests must perform to be clinically useful for their intended purpose. For achieving these purposes, laboratories use calibrators or control materials. In our laboratory, we are using Mindray calibrator and internal quality control materials to monitor our quality goals. For external quality assessment, we are evaluating a national program named as A+. After analyzing the control materials, we have a lot of results of measurement. Commonly, manufacturers define mean and ST value. Users should verify these values after at least 20 serial measurements. In addition to this, laboratory professionals acquire some performance characteristics and their measures. For example, precision measure is ST or CV. Accuracy measure total allowable error. Trueness measure is bias, and traceability measure is measurement uncertainty. Estimation approach can be obtained from the standard experimental protocols available from the CLSI. Accuracy measure is total allowable error. Bias is the measurement of trueness, and measurement uncertainty is for the traceability. So, how can we obtain these measures? Which protocols, which experimental protocols? For example, total allowable error, a measurement is 95% range of differences versus true values and defined IP21. Allowable bias estimation approach is average difference from true values defined in EP09. And measurement uncertainty is 95% confidence interval defined in GUM, EP51 guideline. We create most appropriate experimental protocols for our laboratory in terms of the sustainability of the quality targets we have set. One of them, Six Sigma, is the most popular quality management system, employing for process improvement. Six Sigma methods are usually applied when the outcome of the process can be measured. We make sigmometric evaluations to evaluate the performance characteristics we have achieved. We constantly monitor our quality model by finding operation specification points according to the standard quality protocols we have set. LabExpert supports quality control data management to help laboratory with regular data analysis. We could gain the graphic information from this menu: target mean value, obtained value, standard deviation, and qualification of variation can be obtained from there. We can also check Westgard rules, rule-out, ruling QC protocols. It makes our job easier to follow the standard control protocols we have created. We also monitor whether we have a random error or systematic error from the graphics. We use Westgard rules when we accept or reject quality control measurement. Our preferred rules are 13SD, 22SD, R4SD across 20 parameters. For example, if we evaluate the following values for 2 levels of hemoglobin quality, the Westgard rules violated by these controls are as follows. For level 1, day 2 is a 1,3S rule violation. Day 4 is a 1,2S warning rule, but that becomes a 2,2S rule violation when coupled with the 1,2S rule violation on the same day in the same direction for 2 control. On day 10, there is a 4,1S rule violation. For level 2, the only Westgard rule violation is the 2,2S on day 4. Just as with chemistry and immunoassay, there is no general consensus agreement or standardization on complete blood count parameters. Consolidated summary reveals how large the discrepancies are. Different total allowable error sources are available. For example, for CLIA, for Wisconsin State Lab of Hygiene, New York State PT requirements, College of American Pathologists, and European Society of External Quality Assessment. And you can see total allowable error for the hemoglobin, hematocrit, platelet, WBC, and the other complete blood count parameters. In the clinical laboratory, production and applications of data on biological variation data is essential in order to improve the quality of laboratory testing processes. For this purpose, the main measures derived from BV data and used in the laboratory practice are determination of analytical goals, evaluation of population-based reference values for convenience and assessment of the significant difference between serial results belonging to the same individual. Components of BV are within subject biological variation CVI, which is defined as the random fluctuations around a site point within the same individual. The other is between subject biological variation CVG, which is defined as the variations occurring due to different equilibrium points of different individuals. Calculation of CVI and CVG values is needed for the definition of desirable specification. We could see different CVI, CVA, and CVG results for different population, auto-analyzer, and gender. And they are all different from each other. For completing the analytical phase in optimum conditions, we need to perform an external quality assessment program. External quality assessment and proficiency testing assessment refer to the process of using interlaboratory comparisons to control for variability in the accuracy of an analytical method. For this purpose, we are using a national assessment program named as A+. We could obtain our bias from this assessment. That is the measure of trueness, RSD, RZ score, Z score, R percentage bias, I percentage CV, and our performance is adequate for this program. In this slide, you can see an example of experiment protocol that we are using in our laboratory quality management. In this model, we calculate our sigma metrics, both of using the IQC and EQA measurement results. Also, we calculate total analytical error from the CV and the bias for 2 levels. Through the allowable total error model of laboratory testing, analytical assay performance can be judged on the 6 sigma scale. When we assess the performance of hemoglobin on a sigma scale by calculating the sigma metrics for both IQC and EQA, we can see our sigma levels are upper than 5 and 6 values. Those are accepted, good, and excellent. In addition, operational process specifications have been derived from an analytical quality planning model to assess the precision, accuracy, and quality control needed to satisfy proficiency testing criteria. When we evaluated our imprecision and bias on normalized operational process specifications chart, we are in acceptable, excellent, and world-class area. This is for WBC, and this is the blue one is for RBC, and the black one is for hemoglobin, and the yellow one is for platelet. All these operation specifications points in the excellent and world-class area for our complete blood count parameters. And then post-analytical phase. This phase can be summarized as from the laboratory bench to requesting position. Post-analytical phase comprises interpretation of the test results with appropriate reference intervals and cutoffs, turnaround time, critical value reporting, reflex tests, and re-exam rules. We can manage our post-analytical phase using the lab expert menu information. For example, this is 87-year-old male patient admitted to hospital because of urological complaints. He has been monitored by chest disease departments with chronic obstructive pulmonary disease. And when we analyze the laboratory results, you can see RBC 5.56 hemoglobin level is 11.5 gram per deciliter. He also has microcytosis and platelet level is 51,000 per deciliter. Serum iron level decreased, UIBC has increased. The clinician reported with feedback that they did not expect the platelet result to be so low. On the contrary, thrombocytosis is expected result due to iron deficiency anemia. Causes of platelet clumping include platelet activation and EDTA-dependent antibodies that react with platelet glycoprotein 2B3A. The clumping can be corrected by using blood collection tubes containing an alternative anticoagulant such as sodium citrate. We also noticed FLAG as microcytosis and platelet clump, abnormal platelet histogram. And when we analyzed the sample on optic channel, and the second result is 324,000 per macroliter. As expected, a slight increase in platelets secondary to patient's anemia. As a result of the optical analysis, we see in the histogram the platelets are distinctly separated from the reticulocytes. Blood film was prepared from an EDTA tube and platelet clusters can be easily seen on examination. Our comment on this case is iron deficiency anemia, and iron deficiency increases platelet counts and volume and results in augmented platelet aggregation. Another sample, an 18-year-old male patient without any known disease, was admitted to the hospital with recurrent thrombocytopenia. Platelet count is 54,000 per deciliter. Analytical system give abnormal platelet histogram and thrombocytopenia flags on impedance method. The hematology state that the patient was consulted by many clinical departments and they did not detect a condition related to malignancy or any other disease because of thrombocytopenia and recommended that blood be taken from the patient into a strap tube. On the other hand, we analyzed the complete blood count with the optical method from the same sample. We found that the platelet count was 125. In the histogram, we can also see that the platelets are well separated due to optical staining feature. It is EDTA-dependent pseudothrombocytopenia is the phenomenon of a spurious low patient count due to EDTA-induced aggregation of platelets with impedance method. The platelet results of sample taken into a strap tube was analyzed as 111,000. In the evaluation, while the blood film sample prepared from the EDTA tube can be seen easily, the clusters disappeared in the blood film sample prepared from the strap tube. Two samples showed us this intelligent menu decreasing laboratorian workload and facilitates the interpretation of results. On the LabExpert menu, we may also critical value reporting, turnaround time, and related warnings. Defined re-exam rules, we can see them here. And the critical value message can be seen at the bottom of the program. Finally, when the all phases were done, the laboratory measurement might be used as a patient result. Clinician question is answered by the laboratory processes. Thank you for your attention and listening. Is Pamukkale near our city? Denizli is also known as the Cotton Stones, and Turkish people refer to Pamukkale as the eighth wonder of the world. And the roses from my daddy's garden. Thank you again.
Thank you very much, Dr. Avci, for your nice presentation. We're going to move to our next and last presentation by Professor Prieto Castillo on optimization and development of blood cell analysis. Please go ahead, Dr. Prieto. We can't hear you.
Sorry. Now I thank you, Dr. Adeli, for this introduction. I'm very honored to be part of this panel. I want to thank you, Mindray, and also the IFCC for having me in this lab talk today. I will show you my experience in the optimization and development of the blood cell analysis process, and I'm going to focus especially in samples that are requested for CBC count and differential count in a complete testing. First of all, I would like to introduce my hospital where I work. I live in Chile. This is the capital city of Santiago, and this is the Hospital de Preca where I work. The laboratory is here in the second floor, and we are focused on elderly patients that are part of a healthcare system that is part of the policemen in Chile. The hospital is a 369-bed, high complexity one, and it has 34 intensive care unit beds. We are accredited by a national standard since 2019, and as I told you, it's part of a healthcare system provided for the policemen in Chile. Our main processes are inpatient attendees, also outpatient and preventive medicine. The diagnosis of the patients that are discharged from the internal patients are mainly oncology and cardiology related, and it's very important to take into account that the age of the patient discharged from our hospital, in 62% of them are 60 years old or up, and 28% of them are 70 years old or older. Our challenges as a lab are the same ones as the previous panelists have shown, and every laboratory has. We have to remain very importantly to the quality of the report for safety issues and also for making it possible for the clinician to do his work after us. And we also have to keep in mind their turnaround time and the restricted labor resources and the space of the lab as part of it. I want to show you my experience with this mantra that we are using for facing these challenges and the changes through the last 7 years. And the mantra is making it better, faster, and cheaper. The optimization of the laboratory procedures are always an important topic, as the previous presentations are taken into account. The pre-analytic, analytic, and post-analytical phase are very important to focus on in this way, especially in the pre-analytic. That is the one that has more error risks because it's more manual, it's less fun to be standardized, and as we have been published before, the error here is very important, especially the identification of the samples and of the patient are one of the main concerns for severe patient safety. The second phase that we have to be managing is the post-analytical phase, as I call it the moment of truth, because all the previous work done, good or bad, is going to be represented here in the laboratory result. And the last one is the analytical phase in terms of error risk, where we have more easily standardized procedures and automation and also IT resources to support all the work done here. I'm going to show you this timeline of the laboratory that I lead nowadays. We started to introduce improvements, including a slide maker in 2014. This allows us to make easier the traceability of the samples, including the blood smears with a barcoded identification of them, to be read by this red light scanner that brings the technician, the medical technologist, the information of the patient and the CBC counts to do the differential count in the microscope. This was a huge improvement for traceability, for safety of the patient, and also robustness in the process. As you can see here, the slides made manually before and after with the barcoded identification, and also it's better standardized in the extension and the staining procedures that relies on the result of the microscopy analysis for a better result also in the informed report of the patient. In those days, we had two analyzers connected independently to the LIS, and one of them had the slide maker connected directly. This is our distribution of origin of the routine samples. We have a medium of 300 samples for complete CBC count. 50% of them are from checkups, 16% of them are from inpatient, and 1/3 for outpatient origin. We started to develop our expert rules to exclude the blood smear analysis for the differential count, and this was based on the previous standardization, on the name of the different cells, and we are looking for this international and also national standardization for the report. And we also based the qualification of our professionals based on the results also that the College of American Pathologists and the local national survey program from the Public Health Institute sent to the labs in my country. And also we rely on the quality of the report because of the internal quality control that is peer-reviewed and makes it possible to do a very good benchmark. We took some of the publications those days, just as this one, to set our own rules based on the population that we attend, that is very old and also have many altered results in their CBCs and the differential counts. We discussed with the professionals which were the fears about making the exclusion of the blood smear, and decided our own rules for making this possible. And we started to apply those criteria in the review of a 3-month period, including about 5,000 samples that could meet this criteria for excluding the blood smear. After that, we implemented it during 2015, and 30 to 40% of the samples meet those criteria, and they started to look only 40 times scan with the 40-time objective, just in case, and we started to make it more confident for us to liberate those samples. This introduction improved our turnaround time, and we save time for those samples, starting from 10 to 12 samples per hour, and after this only scan for the samples, we could do 15 to 21 samples per hour in the microscopy stations. In 2016, we did a lab remodel with a redesign that was focused on a new standard and better use of the space with lean thinking process analysis. And also we decided to include a better patient and better sample journey. And we also took into account the comfort of the people working in the lab, so that we could use an optimization plan, open space, and this lean intelligence flux. We included a new LIS and a middleware for the analyzers, the main analyzers management. And we did this remodel in labs of 4 months in 3 different phases without stopping our laboratory work. This was the sample journey before the remodel and redesign, and this was after with a more lean processes and standardization. Then in 2017, we introduced the auto-validation of these expert rules that we have previously developed, and our turnaround time improved in 80% of the workload, doing faster with the same human resources destined to the CBC count. We had 2.5 full-time equivalent before and then. And the indicators that we review those days was that 80% of the workload was done in 6 hours, with only 5% done in the first 60 minutes of arrival. But after implementation of these auto-validation rules, the 81% of the workload was done in 5 hours, improving the first samples that were released in 60 minutes to 30%. After the auto-validation, we did a new tender for introducing a new technology for the hematology analyzers, and we requested 2 analyzers connected to the same slide maker as one module, connected to the LIS and the middleware by one connection, and this improved our processes and standardization, and I'm going to show you some of the improvement then. We kept the blood smear with the barcoded here for the identification, and the slide is very good as well. We reviewed our expert rules and auto-validation that had been set from previous years in this analyzer, and we have had a very good experience with the software of the Mindray platform. This was already shown. This lab expert software is all the information is just in one screen for the medical technologists to review. We have here the daily workload, the patient information identification, also the results from the sample of the day with its graphs here, and also the flags and expert tips and our triggered rules if present here. It also shows the historic results when they are present, and in this section you can see all the process of the sample and the steps that it has been done with it. Also here the reminder flags for the sample list of the day. So it's very easy to use and all the information set in one screen. The overview of the automatic validation rules is also very simple and intuitive in the software. Here you can see that if any of these triggered rules are not followed by the sample, then auto-validation can come. But if any of these rules are checked by the software, immediately the analyzers sends it to a microscopy review or re-exam, that is like an out-reflex testing, or the manual review for checking for the professional to check. This has improved the number of samples that really has to be reviewed by the professional, and is less than 70% of the workload of the CBC and differential count. This application of automatic validation rules has made simpler our workload, following the logical manual review for some of the samples, unifying the review of the standards, and not to get lost in this big ocean of information and data, avoiding missed inspections, many alarms, graphics, etc. And this cannot be received by the LIS, and then we don't waste the talent of our professionals. That is one of the waste of lean analysis, and they can concentrate on the real trouble samples and patients. After this, in 2020, we did a tender for the biochemistry and immunoassay testing, and we introduced a automated pre-analytic sorter that was connected to these new analyzers, and used this as a sorter also for all the lab work and structured procedures. This was done during the pandemic time, and we installed the pre-analytic chain during June 2020. This is a scheme of the pre-analytic automated system that has two entries, and we use this one, the second one. The second one we use to sort all the samples that are not connected to the automated chain of distribution, and one of them is the CAL 6000. This is the sorter and this is the tray that we use to put all the lavender cap tubes, so they are sorted and put it directly in the racks of the analyzer to be taken then and put it in the equipment. This saves times and also makes the people not to be aware of the sorting, and makes it easier for the routine. After the implementation of the pre-analytic sorter, including the auto-validation system that was previously worked, we could reduce our workload time from 5 to 4 hours. And as you can see, the better improvement is in the samples that are already discharged or released in 2 hours, passing to 46% with the same number of full-time equivalent people. And as you can see, the process is much more robust, standardized, and organized after this pre-analytic sorting included. We also use this sorter for the post-analytical phase. After the sample is already run, the same sorter is used to put and to save these tubes in barcoded racks. That makes it easier to find whenever is it possible to, if necessary, to review any sample. And this is what Miriam, one of the technicians, said to me when we took this picture. She loves working with a sorter. I'm going to show you a few cases of the procedure that I already shown to you. This is one of the cases that is going to be auto-validated for CBC and differential count. As you can see, all the results are normal, no flags here, the histogram looks good, and the auto-validation comes around. This is one of the samples that are not included in the indicators that I showed you. This is a CBC request only with no differential count, but it's also suitable to do auto-validation for the sample. This is a case of a patient that was previously transfused with a red blood cell pack, And as you can see, the counter also shows the double population here in the histogram, and also it's flagged here. This patient had pancytopenia that triggered the department to request a microscopic check too. The fourth case I want to show you is a rerun for a very low CBC count. This is the rule that we have here to trigger the rerun setting. The sample was less than 1,000 white blood cell count, and it also requests microscopic check by the department. This is a panic value alarming for the platelet count with a critical value. We had a platelet of 22 here, and it also requested a microscopic examination for its pancytopenia. And the last case is a very interesting one that is similar to the one that Dr. Abchi had reported. This is an auto-reflex testing that is very useful for the interference of the platelet count in this channel that is detected by the analyzer, and it can be done with a reflex testing with a secondary reagent with fluorescent signal that automatically corrects the platelet result. So this saves time and also make more robust and less error in the platelet count. Which were the key factors for our turnaround time improvement? I think the base are the rules for microscopy. Auto-validation was one of the most of impact of them, but for much more improvement, we had to automate and do a lab design with the Remodel, focus on the process to achieve these results that I've shown. And what's next for us? The 2020, we're expecting to prove and develop all the cell digital morphology with this new module connected to the analyzer, and this will improve our oncology reports and also to make possible to do CBC count 24/7 and to make it possible for our improvement in productivity and robustness in the results of the lab. Thank you very much. Thank you also to my team here that made all this possible, and it's easier for me to lead them because they are very motivated and very professional people. Thank you so much for listening to my talk.
Thank you, Carolina, for an excellent presentation, another great presentation. So we have had 4 highly educational and helpful presentations. Before we move to our discussion Q&A session, there will be a video presentation by Master Kevin Zhu from Mindray. Please go ahead.
Hello, everyone, and welcome. It's great to see so many lab professionals from all around the world here with us for the LabTalk webinar, co-organized with the IFCC. Mindray is one of the leading global IVD solution providers. We are firmly committed to our mission to bring healthcare within reach by transforming advanced technologies into accessible innovations to meet even more challenging clinical scenarios. Perhaps more importantly, we are committed to the advancement of the diagnostics field through sponsorship of learning and sharing events such as LabTalk. With the rapid development of the laboratory business in recent years, improving laboratory efficiency has become a hot topic for lab management across the world. So, to present the latest insights on this subject, Mindray is honored to collaborate with IFCC for the first time in hosting this LabTalk webinar. I'd like to thank Professor Costro, Professor Yigong, Professor Tony, Associate Professor Ethan, and Professor Carolina, who are going to share their expertise and experience on how to improve laboratory quality and efficiency. I hope you can all benefit from this webinar. Thank you.
Thank you very much, Mr. Zhu. And I want to take this opportunity to thank Mindray for organizing and supporting this educational symposium. So now we have all the speakers with us to answer any questions that we have. I believe we have some questions in the chat, actually in the QA section of the Zoom. So I can start going through these. The first question is actually from Dr. Halle. It's more of a comment. It says, thank you all. I want to ask a question. Although there is literature information that there will be differences in blood count values, such as hemoglobin reference intervals in the elderly or geriatric population, the result is not recommended for reporting. It is suggested that when the value outside the reference ranges is encountered, possible nutritional problems and or chronic diseases will need to be investigated seriously. So wanted to see if anyone would like to add to that or comment on that. It's more of a statement, but there is a question in there too. So anyone would like to address that? Egon, please. So the idea is, I guess, mostly reference ranges and how you apply that, especially with different populations like geriatrics.
Well, I'm not really a specialist. I rather have some of the specialists answer this question.
Well, I could perhaps comment, because we have been interested in reference intervals for both chemistry and hematology. And we're actually we have recently published reference range studies on various hematology parameters in children, because in children data is very limited. Unfortunately, there is not much information available on geriatric population. Similar to children, data is limited. There is now more data. We have actually published data on several different systems, and we are currently doing a study on a Mindray instrument. That data should be published in the near future. We previously published data on Sysmex and on Beckman systems. So more data is now available in children. On geriatric population, I think data is very limited. There is data on adults, of course, but I think more work is needed in order to appropriately interpret results. This goes, I think actually speaks to what Dr. Aman was presenting on post-analytical, importance of post-analytical step in quality management. Our focus has largely been on analytical quality, but also pre-analytical quality. I think much less attention has been paid to post-analytical quality. And this just, this question highlights the importance of paying attention to post-analytical quality, which means using appropriate reference intervals to interpret test results. Without appropriate interpretation, all of the effort in the lab in relation to analytical quality and pre-analytical quality would be wasted if you do not have appropriate interpretation. So I think that is a comment I wanted to make. So let's go to other questions.
There is the hands up from Carolina.
Yes.
Oh, okay, please go ahead.
Yes, as I have shown in my hospital, we have mainly elderly people. And I think that's the reason that we have a very few percentage of the samples that can be run without validation, because we have many of them very altered results. So I think to have reference ranges for elderly patients is very important and very difficult to the routine labs to investigate. So the results that you will publish, Dr. Adeli, are very interesting for us also.
Thank you. Our current focus is on children, but certainly more work needs to be done in the geriatric population. So another question is how to handle the challenges to joint quality and technical improvements in a big lab. Well, it's a very general question. Perhaps, Tony, you would like to address that. So a challenge is related to joining a quality and technical sort of improvement project in a large lab, let's say in a developing country.
Thank you. It is an interesting question, and really it applies to every lab. So I think the important thing is you need to have some goals. You know, what are you trying to improve? And then you need to use some appropriate tools to ensure that you go through an improvement process in a structured way. So I would suggest that firstly, you need to have a better idea of what do we want to improve? Is it going to be turnaround time or reduce, increase our efficiency, or what are we trying to achieve? And then use a tool such as Lean, where you look for, you address the problem in a specific way, you look for outcomes, you use evidence, and then put those two processes together. So I think you need to know what you're trying to achieve, and then use a tool that's based on principles of Lean, so that you use evidence and you look at what your customers want, and then put that into place. And then, of course, once you start, you need to continue. So no process in any lab or any organization should involve just one sort of iteration. You need to keep going. So what are you trying to do? Use the right tools and just keep working on it.
Thank you, Tony. So maybe the next question Dr. Avci could address, it's if we keep on updating the baseline for every lot change and calibration done, is it possible to achieve Six Sigma score or quality?
Yes, a good question. Every lot calibration and quality control lot changing, we set the quality goals again and again, and we are doing this in monthly, in weekly, in periods. We at least we experiment 20 experiments for 3 levels and obtain the results of measurements and estimate our ST, CV values. And monthly, we obtain our bias values from the external quality assessment, and we make our sigmometric evaluations in monthly period. Thank you for the question.
Thank you. This question is for Professor Carolina. How did you set up and adjust auto re-exam rules on LabXpert software?
Thank you for the question. The hematology analyzers have a very easy to use softwares nowadays, and the rules can be set right in the software of the analyzer just to sort which samples are going to be read in the blood smear. So the slide maker does the work to sort all the samples that are going to be really going to the microscopic stations, and those are set directly on the counter software.
Thank you. Maybe this question can be addressed by Professor Aman. How to balance the lab management or lab managing sort of in any clinical lab on manpower efficiency. So balancing, the amount of resources going into lab management and in light of how much resources you have, manpower you have, and how do you ensure that it's used efficiently?
Yeah, that's also a very general question, and that applies to each size of a laboratory, I think. As I try to point out, it is very important to start with this, what I call the bottom-up approach, to really establish first the analytical quality tools. And so the question is always, do I need a quality manager just in a person? This depends on a lab size. Of course, larger labs have this, let's say, centralized in a person. Smaller labs might have to do this in a shared responsibility. I see it more from my time as a manufacturer. I think it is very important to keep track of all the standards and regulations. This is something that of course, laboratories, medical labs, as well as calibration laboratories, as well as EQA providers, as well as manufacturers, their final control is always the audits. They can be internal audits, they can be external audits. Sometimes the FDA comes for a manufacturer. And then this is giving, of course, a lot of feedback. So my recommendation is really to set up an internal audit program to pre-actively find the issues in the lab. And of course, this is then intertwined with this software and lab interpretation software. And I would vote from a minimum size of, let's say, 20 people to have a centralized function. And then, of course, you have to set up CAPA systems. You have to set up maybe digital signature process for your system. So it is a very general question, maybe two-sided at least. One is really keep a close track on the regulations, and that is a lot of work actually. And then try to organize it in a way that you have shared responsibility, but in the end, the lab quality manager or the managers will be asked. I hope that answered the question in a general fashion.
Thank you very much, Egon. So actually, there is a related question that Professor Badrick perhaps can address. Is related to cost. How to effectively control the cost in a lab? I guess, meaning ensuring high quality, but also ensuring cost efficiency. You have a lot of experience in this regard, so please, Tony.
And again, it's a difficult question. And I was going to say it's always useful to try and benchmark. You can't always benchmark costs because people might not tell you what their costs are. But sometimes if you can find another lab that's like your lab in terms of the patient population, the testing range, whether there's out of hours requirements. So sometimes you can start by looking for another lab that's like your lab and just seeing if they've got the same number of FTEs, how are they dealing with workload, etc. That can be a useful a pointer as to what you should do. In terms of costs, again, I'd suggest looking at costs. Costs are really related to waste. So your costs go up if you've got waste. And waste can be in terms of time. People are doing, as we've seen in some of those excellent presentations, people are doing very manual tasks. So that takes a lot of time. Introduce auto-validation and a lot of those manual tasks disappear. They can be waste in terms of tubes not used or reagents not used, so that begs a lean process. So look at what you're trying to achieve. Again, set the goal. Are we really as efficient as we can be in doing this assay or in this laboratory or with out of our service? And then use a lean process, a proper process where you capture data, look at what the requirements are, and address that in a structured way. I think that's the way to go with any of these problems. Define what the problem is you think. And now when we're talking about costs, we're talking about waste. Try and identify that waste and how can we reduce that waste, be it in labour, volume of equipment, reagents. Look at all those areas of waste and how can we reduce them, and use a tool to approach that, a scientific tool such as lean.
Thank you very much. And I think the key point here is minimizing waste, ensuring that you have a lean, efficient process. So reviewing your lab processes, lab workflow, and minimizing waste. And there is a process called the lean process that you can apply to your lab or similar processes to improve efficiency. And that's the best way to reduce cost and save money. Now, so let's go to another question well, actually, this could be addressed by Dr. Esin Nafji. If I want to set up the lab target value on hematology analyzer, how much the procedure, I guess the meaning, what procedure to follow?
Really, Dr. Adeli, I don't know how much cost because I'm only a laboratory quality management director in my laboratory. Our hospital administrative management desk and the hospital chief doctor is conducting this area. I do not know. I'm sorry, I can't reply this.
No, I understand. Anyone else would like to comment? If not, maybe we'll go to another question. Maybe Professor Carolina can address this. Can we measure plasma hemoglobin by running plasma sample on CBC analyzer?
Sorry, I didn't get it.
So instead of, I guess the question is, normally whole blood is UMA and DBC analyzer.
It's usually done in Chile. We use the EDTA sample with the lavender tube that's whole blood for the analysis of the hemoglobin. And there's also done in the hemoglobin. You can also do it in the point of care critical testing that is also done in these tubes that are with the plasma or serum based. So I think the hemoglobin can be done in different kinds of samples, but in the hematology analyzers, there's always a total blood for that means. Mm-hmm.
Yes, that's my understanding. So for if you want to measure plasma hemoglobin, best to use other instruments, not the CBC analyzer.
Yes.
Normally, like you can actually use your blood gas analyzer to do that.
Yeah.
Because blood gas analyzers measure hemoglobin. You can actually, there are chemistry tests as well. But for hematology CBC analyzers, normally whole blood samples should be used, as Professor Carolina mentioned.
There's also some methods to measure free hemoglobin that is like a point of care testing. That is suited for patients, for example, in a coronary unit that are connected to the ECMO support. And those patients need some of these measurements to adjust the ECMO machine.
Thank you. Actually, there's another question for you. Please repeat, what equipment do you use for auto-validation and sample sorting?
Okay, we started our auto-validation rules with Coulter Beckman Coulter analyzers, and then we changed to the Mindray platform, and we reviewed again the rules before starting the routine samples on that platform when we changed it from one tender to the other.
Thank you, Carolina.
Okay.
Another question for Professor Aman. What is the best way, perhaps both Professor Aman and Professor Badri can address this, what is the best way for a private lab in Zambia to get ISO and international accreditation?
Yeah, I try to answer that question. Of course, it actually came to me because I was addressing the African situation a bit. In our previous activity, the so-called DECO-CML, developing developing quality in laboratories in the developing world. We had an activity also with, I think, 10 or 15 labs in Zambia, which was modeled a bit, as I told you about the SLIMTA situation. So I'm not a specialist, of course, for accreditation and for EQA participation, and I don't know, of course, the accreditation bodies. But there is, for example, one in Kenya, which is HUKAS, HUKAS. Maybe they are active in Zambia. I think you have to really inform yourself what is the what is the national accreditation organization in Zambia, and they are so different in the whole world that, of course, I don't know them by heart. I would really go the following way: talk to your Ministry of Health. See if they can give you some advice. What is the accreditation? And then, of course, there are local or international accreditation bodies which you may contact. What I can also do, if you, it's an anonymous listener, if you contact me at my email address, egon.ammann@t-online.de, I could give you some additional information. One of our team members in the task force of global lab improvement is Renze Bice, and I think Tony knows Renze from Australia, and he was heading this EQA program for Zambia. I would bring you together, and maybe from this contact we can develop a more concrete action for you.
Thank you. I wanted to add that the IFCC has begun a program called the Global Lab Quality, and this program is just starting. We are in the planning stage. Professor Ammann is actually a co-chair of this, and Professor Meng from the US. The two of them are leading this initiative, and we have representations from many countries around the world. This task force is actually planning to start a program early next year in 10 countries. I believe Zambia is one of them.
Zambia is one of them, and we have 5 labs identified, or was let's say given to us by the Zambian organization. So maybe this anonymous listener could get a link here and could be queued in this activity. But it depends, of course, now on your initiative.
Exactly. So 10 countries around the world, in Africa, in Latin America, in Asia, and in Eastern Europe, are starting a pilot program next year. And IFCC is supporting that and will be funding that. And there will be EQA provided, external quality assurance material provided, training provided. And so more information will be announced soon once everything is planned. We're currently trying to finalize collaboration with a partner, with a EQA partner, so that we can actually start that program. So that's coming. And so hopefully IFCC, working with companies such as Mindray and others to support more of this type of activity around the world to enhance quality in countries everywhere. Our idea is to enhance global lab quality in all areas of the world, in all regions. And so this is just the start. Dr. Patrick, please.
I was just going to add, not much more to that, but don't wait. Accreditation is just, that's the prize that you get, but there's a lot of work you can do before you get there. So I'd suggest that you get some of those guidelines that Professor Ammann mentioned, or look at ISO 15189 and start doing the gap analysis in your laboratory now. So start the work towards the accreditation. That's the best way to get going. The accreditation is say it's the prize, but in fact the work that you do is worth it. So start the work.
Thank you. Perhaps one last question I see that we could try to address. One of the attendees is asking, perhaps Professor Essien or Professor Carolina can address this, is can you talk about NLR or PLR parameter? Have you measured those, and if you have any comments?
Excuse me, can you repeat?
I'm not sure what is meant by
What is
NLR
NLR?
and PLR.
What is LR?
I'm
What
not
is
sure.
NLR and PLR?
PLR?
Yeah, PLR and NLR, but I don't know if
Platelet lymphocyte ratio, neutrophil lymphocyte ratio, meaning?
yes, I think so. The ratios, it must be ratios. Yeah.
Yeah, it's more common in COVID disease recently. Platelet lymphocyte ratio and neutrophil lymphocyte ratio are the important ratios about patient monitoring in intensive care units. If the ratios are upper than some cutoffs, I don't remember now, the patient is going bad in intensive care unit, we can say. It is there are monitoring ratios for the disease monitoring in services or intensive care units, I know.
Okay, thank you very much. Any other comments from Carolina or anyone else?
No, I think Dr. Avicii had already answered.
Okay, thank you. So I'm going to just share you one slide. Just give me a second. I'm going to share my screen so that we can conclude our program. So I just wanted to show you the concluding slide. Thank you. I want to first of all thank all of the speakers for their excellent presentation, and for I think we had close to 300 participants, perhaps more, but the Zoom was showing quite a good turnout. So thank you all for participating. We had an excellent series of presentation and good discussion and good questions. If there are additional questions, you can send them to your Mindray contacts, and we'll be happy to try to answer them. So thank you all for participating. Please, you can use this QR code to receive a certificate of participation, so that would be the easiest way to get that certificate sent to you. So thank you all. If there are no other questions or comments, we will conclude the presentations. Thank you all. Thank you, Egon. Thank you, Tony. Thank you, Carolina. Thank you, Essien, for participating as a speaker.
Thanks to all of you. It was a
Thank
good
you.
meeting.
Thank
It was a
you.
good webinar.
Thank you.
Thank you,
And thank
everybody.
you, thank you
Bye-bye.
to Wendy Lee and the Mindray for organizing this very nice program. Thank you. Bye.
Thank you very much. Bye.
Bye-bye.
Thank you, professors. Thank you.
Thank
Bye-bye.
you.
Thank you.
Bye-bye.
Thanks for all.
Bye.
Bye.